To all of you. I welcome you all for this fourth session of What Do the Experts Say session of EOC in India. We have finished three earlier, and today's session will be on neuropalliative care, what a pediatric neurologist should know. I'd like to request President Dr. Shefali Gulati to introduce this talk, the speaker, and the experts who are going to join us today for this meeting. Over to you, ma'am.
Thank you, Mahesh. After having what is the personal genomes and the situation, then the genomics of cerebral palsy, and what were the recent advances in Duchenne muscle dystrophy. Today, we will be talking about what can a pediatric neuropalliativist do and what a pediatric neurologist should know. And I think these are areas which require to be focused on. And we will be having the talk being delivered by Dr. Roop Gursahani, who is a consultant neurologist, PD Hinduja Hospital, Mahim and Khar, Mumbai. He's in the board of directors of the International Neuropalliative Care Society, trustee of the Forum of Indian Neurology Education, and member steering committee, Elicit End of Life Care in India Task Force, a joint initiative of Indian Academy of Neurology, IACCM, and IAPSC. His interests are epilepsy and neuropalliative care. Along with him, after his talk, we will be having 4 experts who will be deliberating, on the thing, and we'll be having some cases being presented and other discussions on the personal experience. We have Professor Sushma Bhatnagar, who is MD Anesthesiology, MSc Palliative Medicine from the Cardiff University, and she's heading the National Cancer Institute and chief of the Cancer Institute, IRCH, in All India Institute of Medical Science in New Delhi, and she's president of the Indian Association of Palliative Care since 2018. And she has so many rewards and awards to her credit, and publications 336. We are really grateful to it's for Susie Holt to have joined. She is Bachelor's of Medical Sciences, BMMS NOTS in 2004, and she completed her pediatric specialist training in Trent and Mersey regions in the UK, and she had a postgraduate diploma distinction in complex care in children, young people, and families. She's also completed training in understanding and working with child loss and bereavement in counseling and helping relationships, as well as advanced communication skills. She became a consultant in 2016, and since 2018, she has worked as a medical lead at Clare's House Children's Hospice. Her current post is consultant in pediatric palliative medicine at Elder Hay Children's Hospital in Liverpool. And she is an education advisor to the Royal College of Pediatricians and Child Health for this specialty. So her particular interests are complex symptom management and delivery of palliative care in the critical care setting. And I'm really very grateful that you have been able to join us. Then we have Dr. Virat Sanghi, who is MD and DNB in neurology with fellowship in pediatric neurology from Toronto, and has had special training PCEP from Boston, USA. He's consultant pediatric neurologist at SRCC Children's Hospital and KM Hospital, St. G.S. Medical College, Mumbai. And along with the stroke and neuromuscular diseases, his area of specializing is in pediatric neuropalliative care. And he's trustee of the Neurology Foundation. We are also grateful to Dr. Manjari Dige, a consultant in pediatrics at the Al-Adan Hospital, and she leads the care of pediatric patients with palliative care and complex care needs in the hospital. Prior to joining the Al-Adal Hospital, Dr. Manjari served as the medical director at the Cipla Palliative Care and Training Center in India. The center has been providing palliative care for adult and pediatric patients with cancer over the last 20 years. Dr. Manjari oversaw all this, and then she began her palliative care journey in Kuwait way back in 2013 as a lead consultant as the Bait Abdullah Children's Hospital, Kuwait. She was involved in developing clinical services regarding the same. And she had completed her training of the palliative medicine from Cardiff University, and she has completed her Bachelor's of Medicine and Bachelor of Surgeries from the Lokmanya Tilak Medical College, Delhi, and MD Pediatrics from St. G.S. Medical College. She's a faculty member of the Indian Association for Palliative Care. And I'm really, we have such a learned, speakers and other experts. And now we will have the flavor of the the adult neurologist who is pioneering in India, as well as, pediatric neurologists who are looking after, and our pediatric neurologist who has gone to Kuwait, and we have Dr. Sushma Bhatnagar, who has been heading the palliative care in India and has been pioneering the same. And then from the other side, we will understand from Susie that what are the needs and how it stands in the high income area, and what the lessons we can learn from her. Over to you, Ru.
Thank you. Thank you, Shefali. It's a pleasure speaking to this audience, and it's obviously great to be in the company of Dr. Sushma Bhatnagar, Viraj, Manjari, all old friends, and nice to meet Dr. Holt as well. So I'm going to begin by sharing my screen, and I guess you know that I am not a pediatrician, and well, I suppose I could call myself a neuropalliativist. That's a term that I think I've invented, but it suffices for my purposes most of the times. And part of this lecture is something that I'm giving for the International Neuropalliative Care Society, basically palliative care providers who need to look after child patients who transition to adult palliative and adult neuropalliative care. So, a quick fly through the taxonomy, scope, and ramifications of what we are talking about. A little bit about the basic principles of successful transition, because although that applies to individuals who are reasonably independent, you have to factor that into account when you're transitioning patients who are going to lose independence a little later. And broadly, understanding the principles of neuropalliative care in the life journey of a patient and a family when a life-limiting neurologic illness comes up. So we'll quickly look at this. Remember that static disorders, progressive encephalopathies, progressive element syndromes are all part of what the remit of what a pediatric neuropalliativist would need to do. But these skills actually, once you start applying them, actually come through into practically everything else. Again, I won't really dwell too much on this slide, except to point out that the common medical themes throughout these illnesses are cognitive impairment, motor impairment, sensory impairment, and seizures. And for instance, cognitive impairment, we think of it as behavioral and psychiatric abnormalities, but in a young adult, it could be lack of capacity. Motor impairment obviously is of various types, and seizures and their management are also pretty important throughout. The journey actually begins with so many patients with prenatal diagnosis. All of you know about the advances in non-invasive prenatal testing, the fact that cell-free fetal DNA in the maternal blood allows you to detect aneuploidy, and that trisomy 21, of course, tends to get picked up the best, most easily, but others also are now coming up through. We know that ultrasound starting at 12 weeks, but going on to about 18 to 20 weeks, should identify most severe anomalies, especially if you use level 2 ultrasound. And then, if needed, MRI has to be performed significantly before the legal limit for MTP, in case that needs to be considered. We are understanding that one of our duties is a fetal consult for for potentially life-limiting diagnosis which appear in utero. We have to understand that there are limitations in imaging, and you may have to incorporate information regarding other systems other than the brain, other than the nervous system, and also incorporate genetics. Prognostication is not always easy because you are extrapolating from the population to the individual, and you have to convey both uncertainty and the possible range of outcomes to get to shared decision making in this space. When you manage these patients, you need multidisciplinary management, especially when it is more complex. But remember, multidisciplinary doesn't mean multi-person. You could actually incorporate many of the skills and the knowledge that these different specialties have. And that, I think, is the key of becoming a neuropalliativist, that you take on all these roles, or at least understand how these roles are going to be performed. Obviously, prognostication is a major part, and I'll come to that a little further. So, for instance, look at Down syndrome. Trisomy 21, the most common survival aneuploidy. The standard features: short stature, hypotonia, intellectual disability, atlantoaxial dislocation, congenital heart disorders. But for me, as an adult neuropalliativist, early onset Alzheimer's. And if you realize, although the overall numbers are rising with rising maternal age, there is also a higher tendency to medical termination of pregnancy in these patients as diagnosis gets done. Now, this part of the lecture, and even further, well, we need this lecture because both children and parents grow up and old. These diseases progress, complications arise, adult illnesses appear, social needs change, psychological issues can get worse, and there is no clarity on which medical specialty takes care of them, especially when they transition. As we'll see, some of them are likely to die early, and new treatments will appear and not be used because of lack of awareness. So I'm kind of separating this into those where you are handling transitions with non-life limiting but lifelong illnesses, but also transitions with life limiting neurological illnesses and the in between. So you can see there will be overlaps. The classic example is epilepsy. You could obviously have controlled epilepsy, a cognitively normal individual who's unlikely to remit and will go on to need medication throughout life, JME. Partially controlled epilepsy, largely cognitively intact, well, temporal lobe epilepsy. But you also have intractable epilepsy with cognitive delay. And this will mean about 75% of children with symptomatic generalized epilepsy will survive well into adulthood. Infantile spasms will lead to severe learning disability, and many will present with psychiatric symptoms as well. So also with LGS going on to adulthood, and well, somebody has to manage them. So transitions are the process of accompanying a person through adolescence to adulthood. It's a planned process that addresses medical, psychosocial, educational, vocational needs as they move from a child-centered to an adult-oriented system. Adult care is individualistic. The dependence on parents is no longer possible. And here, medical issues have to be explained to the patient. We differentiate this from transfer, which is a point in time when the responsibility is handed over from one provider to another. And as you can understand, one of the major difficulties is identifying an appropriate adult physician. So the goals are to prepare the youth to understand her chronic illness and take responsibility, empower both patients and caregivers to allow them to function as independently as possible, and identify the appropriate adult healthcare providers. Even if an appropriately trained adult neurologist is not immediately available, transition planning should still apply, and there has to be effective communication between the two sides. So one of the things that has been learned is that starting in early adolescence, children can be explained how to take charge. And this could be, for instance, a patient who does have some cognitive difficulties, but is still able to say that I am 31 years old, I have epilepsy because of brain damage, I'm getting only minor seizures, I'm on oxcarbazepine, and so on. And be able to explain her concerns. So this is the three-sentence summary that SickKids propagates. The Child Neurology Foundation has put a list of best practices. They suggest that this discussion has to start by the 13th birthday. Self-management skills need to be assessed by 12 years and then reevaluated. And annual transition planning sessions actually start from that age onwards. Issues of puberty, sexuality, genetic counseling, reproductive implications need to come up fairly quickly. Risks, especially of driving, need to be explained, and we need to start focusing on overall wellness as well. As I've said earlier, a comprehensive transition plan needs to be developed so that adult providers are identified. And obviously, I mean, this is a fairly formal kind of process. Not sure that it is often done in India, but it should be. And there is one more wrinkle that in India, we are still not up to speed on, and that is to assess and address expected legal competency. After the age of 18, an individual is supposed to be legally competent. And if one is certain that they are never going to be, then this is something that needs to be discussed. We don't have formal legislation to this effect, but I think we'll probably get this one. So there are some special needs. One is that because of concomitant intellectual disability, as parents age and pass away, well, they become individuals who are well known to no one. You can have unusual rare neurologic disorders where treatments are evolving. And probably the solution is that these individuals need to be connected to support groups. Disorders that evolve in adult life in an unexpected or different way, well, epilepsy can change. Fragile problems can deteriorate suddenly. OTC deficiency can come in severe hypomonemic crisis in adulthood, minor infections, and nobody may know what's happening. Dravet syndrome's treatment may not be familiar to adult neurologists. Disorders that were previously lethal now have treatment, and so on. And in both ways, disorders that are better managed in adulthood versus those that can have very severe manifestations in adulthood. For instance, tuberous sclerosis ends up with chronic renal failure later. And disorders that remit but have serious comorbidities. So this is as far as conditions that possibly people can live with. But what about conditions that will inevitably progress and cause early death? So for many reasons, palliative care has traditionally been rooted in oncology. It began because of the special needs of oncology patients. And oncology patients have voice till the end, and their major needs are pain. So in some ways, it becomes a little simpler to manage them, as oncology at some point hands over to palliative care, and palliative care then takes them, well, over the finishing line. That's not the way it works in neurology. In neurology, we walk the life journey with the patient, starting at diagnosis, going on through life events and symptoms, appearing disability. Some patients, of course, will have the good fortune of disease-modifying therapies and will survive. Those that do not, well, we need to have serious illness conversations first with the parents and then with the patients themselves. Advanced care planning applies, especially in adult neuropalliative care. Psychosocial and spiritual support is necessary throughout, and under recognized component is rehabilitation, care partner support, and then finally preparing for end of life care. All of this is part of the remit of neuropalliative care. So we start off, say, for instance, with the diagnosis. Now, if you are looking at giving a diagnosis, remember that when you are giving a diagnosis, please be aware. Even though you think the diagnosis is no big deal, you may be the first physician to tell a mother that her child has epilepsy, and it's a bomb that drops on her. On the other side, you know this is a disease that the patient will die with, and you may find it personally difficult to tell the parents in front of you that this is what is going to happen. or there is genuine uncertainty, but it's potentially treatable diagnosis. In any case, whichever way you tackle it, you need early follow-up to deal with the aftermath and to present this diagnosis. You need to learn the basic elements of protocols like spikes or breaks. Most of us use spikes, and I'm not going to spend too much time on this except to tell you that this has now been around for more than 20 years, and most of us use this sequence. Make sure that the setting is right. You don't do this walking in the corridor. This is something that needs to be planned for. Start off by checking what the family knows. And then, obviously, I mean, this applies more to the adult world where you have to first find out if the patient wants to know. Typically, parents, it's unlikely that parents might not want to know. Then you give information, deal with emotions, and close by summarizing. Again, we are holding communication skills workshops for neurologists who are interested in this, and I'm sure this is something that we can do for the pediatric neurology world as well. If you then start to look at the road ahead, remember that we are told of the 5 Ds of prognosis: death, disease progression, disability, drug toxicity, and the cost. But it's much easier to simplify it into these two for neurology: how long and how long. Typically, you have to prepare the patient, the family, for upcoming signposts of decline. Obviously, in a younger child, there is going to be a long period of perhaps growth before that happens, but sooner or later that may have to be tackled. Remember that uncertainty is part of the game. Disease-specific data are not reliable in terms of an individual patient, and that is why we prefer to use this framework: best versus worst case versus the most likely. You may occasionally need to give data numerically with a likely time frame. That's usually in acute situations, but as far as possible, you have to give ranges. But more importantly, for anyone who starts on this, remember that it's a mental pivot that you make when you take on these patients. We are used to curative medicine, where we seek to return patients to their own lives so that they can do what they want to do. Palliative medicine seeks to assist patients in leading their lives and to support them in the pursuits that they wish to prioritize the time they have left. And we do sometimes both together, sometimes for decades. Probably the one thing that you must never say is, I can do nothing more. That is not okay. There is always something, in fact, quite a lot that we can do as we look after them. When you plan follow-up for these patients, typically, if symptoms are pretty high, I usually suggest a 3 to 6 month follow-up, or if they are stable, then you can make it an annual follow-up. And ideally, you need to set up at least an electronic contact mechanism for these patients. You have to be aware of major life events as pediatricians. I think that's something that most of you do, but for adult neuropalliativists, it's not a usual thing. How far would you strive for a diagnosis when the diagnosis is not clear-cut? Remember that we are now beginning to expand the scope of genetic diagnosis. It's important to have a diagnosis because it does relieve the caregivers, the parents' anxiety and uncertainty with specific information about inheritance and prognosis. And it empowers them because they can then embark on support groups, advocacy, and so on. It limits further diagnostic testing, and it allows prevention of recurrence in family members. So, for various reasons, understanding available treatments, long-term prognosis, coexist conditions, recurrence, for all of these, I do think that we have to go ahead with genetic diagnosis as far as possible, even if it is, say, an older adolescent or a young adult where this may not have been done earlier. And then you start planning uh, the transitions. You may have access, I mean, the patient may have access to a neurologist with a subspecialization who can take this over with a multidisciplinary clinic. But more often than not, you're going to be looking for a kind of a broad spectrum adult neurologist who does accept some amount of palliative care skills. In the later stages, you may also need to liaise with a palliative care physician or a palliative care team. Remember that the symptoms are substantial and they can span the full range, and it obviously will depend on what condition you're dealing with. I'm not going to really do the details except to stop by whenever I think it's important. Remember that the overall symptom burden in life-limiting neurologic illnesses is as much or more than in terminal malignancy. There's a difference in symptom profile, even though the pain is not the same as cancer pain, but it can be substantial. Neuropathic pain can be substantial. And because these individuals may have limited communication, it may not be so easy to communicate with them. Psychological, social, spiritual pain needs to be assessed early before communication is lost. And remember, there are many symptoms that are specific to neurologic disease. Non-motor symptoms, mobility challenges, behavioral and psychiatric issues, motor symptoms such as spasticity, cramps, fasciculations, drooling, and so on. Probably one of the ways that we can help them best is to try and plug them into peer support groups. Now, peer support groups are a group of people with common experiences and concerns who provide emotional and moral support for one another for a shared and burdensome characteristic. And this help is non-professional and non-material. Much of it has to do with information sharing, especially coping strategies. And they may be able to actually inform each other about services and products. Personal experiences and a shared space, safe space, are also important attributes. And these communities that are built actually are very powerful in terms of advocacy. The very interesting thing about the internet is the rise of these online support groups for rare conditions, because they overcome geographic separation. There is an issue because especially if you are not, if your provider is not able to plug you in, it may be difficult for parents to find this out on search engines. If it works, participation can be synchronous, and the personal experience that peers give is really is something that they really value. For us, well, if you are in any way monitoring or around during these, remember that you need to look for support groups that are caring and compassionate, that are active and vibrant. Typically, there are some people who are very active, and you can see the true sense of community that develops. I am a intermittent watcher in a motor neuron disease support group on WhatsApp, which is based out of Mumbai, and I can tell you it's really quite something. There is evidence that these support groups empower patients and families because of enhanced self-efficacy. They do help with anxiety and depression, and eventually help with adjustment and so on with quality of life. This has been documented for malignancy. I'm sure there will be some similar literature in cases in pediatric neurology. Right. So there is another issue that comes up, and this is especially true if you're dealing with individuals who have a fair amount of cognitive, who are cognitively relatively normal, at least in the initial part. And for instance, in patients with Duchenne muscular dystrophy, as they get older, remember the rehabilitation, attention to respiratory issues, gastrointestinal and nutritional issues well, you have to take care of the whole range of what is possible. Uh, you will also understand that these are uh, adolescents and young adults who have significant mental health and psychosocial needs that need to be addressed. And all of this takes a multidisciplinary team, but otherwise you have to pay attention to them, these issues as and when they arise. So, not just in DMD, but in other neuromuscular conditions, remember that rehabilitation has to be built into the management plan. Ideally, it should be disorder specific, but if not, then you may need to be aware of professional colleagues who are interested in each of these fields. Well, this applies more to adults, but aerobic exercise can be a group activity. Range of motion exercises are something that the home caregiver can do, and you can get very good resources on the net which show you how to do this. For young adults who can participate in this, supervised exercise can include weight training and balance and gait training. Remember that if, of course, this is true of motor neuron disease, weight training is a double-edged sword and needs to be carefully monitored. Occupational therapy helps adapt for activities of daily living by helping them, showing them the use of assistive devices. Speech and swallowing therapy is pretty important, especially when bulbar function is impaired. And obviously, cognitive rehab or special education is going to be important for these patients. It's important to realize that palliative, rehabilitative, and curative care actually are three overlapping circles, and we need to be aware of the not just the boundaries, but the overlaps between them. So as you go on through somebody who's who has or is beginning to develop severe disease, remember that quality of life depends on participation in community activities as long as possible, maintained ambulation and independence, and towards the end, you are looking at maintaining comfort. This medical management, again, needs intervention on various aspects, not just symptoms, but also nutrition. And I've shown you a similar slide for Duchenne's muscular dystrophy. It's good to get palliative care team engagement reasonably early because you can then connect, manage home nursing. And towards the end, although we do not have hospices that can take care of individuals at this stage of life, remember that almost all the metros have home care, palliative care teams who will assist, but you have to know how to access and use them. Along the way, one of the issues that dominates management in patients who have cognitive impairment are behavioral and psychiatric symptoms. And you can have a wide range, delusions, hallucinations, sleep disturbance is important for both patient and caregiver. One of the things that often is an issue is disruptive vocalization or disruptive behavior generally. How do you screen for this? So you can ask both the patient and caregiver, are there any behaviors that worry you? And you could ask directly if they see things that aren't there. How do you sleep at night? To manage them, the first thing is to assess whether they're just annoying or really dangerous. The more severe ones need to be analyzed in terms of what's termed ABC, antecedent, what sets off this kind of behavior, what is the behavior, and what are the consequences of the behavior. So somebody who doesn't like taking a bath can start off being verbally abusive, or then physically abusive, and then you may have a caregiver who's injured. So you need to be looking at this. If need be, these are patients who may need pharmacologic treatment for control. Another huge component are the carers. the impact on the caregiver is substantial. There's both physical and emotional impact. Psychiatric morbidity is known. The risk of burnout is significant, and anticipatory grief as the patient starts to deteriorate is all known. For us, it's important to assess this. You can use the Zarit Burden interview of this, but probably the most important is to acknowledge it. As clinicians, this is something that we must never miss out on doing. Literally, the last question as the patient is going out of my room is, as the caregiver follows, is to ask them, how are you doing? And if it needs a certain amount of attention, it doesn't take long. But you can help them by pointing them in the right direction and so on. Support groups, as I said, are very useful here. Remember that there are multiple roles that can happen in relatively independent individuals. You have a care partner who basically does the logistics. In somebody who's more dependent, you have the caregiver. And fortunately, in India, we have the ability to pay for paid caretakers. And when you see, say, a younger adult or maybe even an older one who has a paid caretaker, it's important to find out how long that person has been there in that role. There are times when these are individuals who are probably closer than family. Otherwise, the relationship with the individual needing care, yeah, you need to, it's not always the patient. It could be siblings as they get older. What about the health status? What about the other commitments? All of those we need to keep an eye open for. Remember that the caregiver's role is not just physical assistance and support for activities of daily living. They are also going to be largely the surrogate decision makers towards the end of life. So, when you look at approaching the end of life in neurological patients, remember that there are the triggers obviously will depend on the specific condition that you're dealing with, but some generic triggers are swallowing problems, marked decline in physical status, recurrent infections, especially the first episode of aspiration pneumonitis, the new onset of delirium in somebody who, well, you may not have realized had cognitive impairment, weight loss, and significant complex symptoms, pain obviously, but others as well. So it's important to understand that at the end of life, there are basically three broad pathways. In somebody who has low motor neuron disorders, for me, of course, this is motor neuron disease, but for you, it could be spinal muscular atrophy. They start on by developing bulbar failure, swallowing difficulties. This goes on to respiratory failure and death, obviously. Or sometimes if they are on invasive ventilation and with feeding tubes, then they effectively end up in the locked-in state. In individuals who have cognitive failure, bulbar failure usually accompanies loss of mobility, and again, it is possible that death occurs in this state if feeding tubes are not inserted, but if feeding tubes are inserted, they are likely to be able to maintain respiration, and again, they end up in the vegetative state. Now, in other CNS diseases where you have a combination of motor and cognitive, the individual trajectory literally will depend on your assessment on their personhood and how it impacts quality of life. How does this work out? Remember that the option of clinically assisted nutrition and hydration, whether by nasogastric tube or percutaneous gastrostomy, and remember that PEG tubes have been documented to reduce the risk of aspiration, but definitely have a better body image. For instance, in patients with motor neuron disease, progressive motor neuron disease, it has been shown to delay the onset of respiratory failure. It has to be done before post-vital capacity drops below 50%, because if you're closer to 30% of FVC, then there's a good chance that the patient will end up getting intubated and ending up with a tracheostomy during the performance of the PEG. I didn't have the time to look up the literature on SMAs, PEG and SMAs, but I'm sure the same principles will apply. And in MND, early PEG delays the onset of respiratory failure to the extent of almost 6 months or up to a year, and it is strongly recommended. On the flip side, because in patients who have cognitive failure, in dementia, because you're looking at somebody where bulbar failure occurs literally just one step before the patient literally has only residual brainstem function, like a persistent vestige, we do not recommend either ICU or percutaneous gastrectomy. What about respiratory management? Well, in situations where this is predicted and where adequate counseling has been done, the preferred mode is non-invasive ventilation and transition to dyspnea control with morphine. Invasive ventilation with tracheostomy is obviously possible, but again, as I said, these are individuals who will land up in the locked-in state, and the carer's quality of life continuously goes down. I will quickly end with speaking a little bit about what happens with serious acute neurologic illness. Remember that this is, in a sense, an artifact of modern ICU care. Somebody whose brain was hit by a clot, accident, or whatever, earlier would not survive. Now we make them survive through respiratory failure. Some of them obviously still die, but a significant number will improve with disability. When you have to make decisions, remember that the initial decisions, usually the first 1 to 3 days, are as regards intervention. This could be neurosurgical salvage, or it could be neurointervention. But generally, these decisions happen fairly early. Around the same time, a little later, brain death determination can happen. The next major point of decision making is intermediate. At the end of 2 weeks to maximally about 3 weeks, when you have to decide if that individual is going through for a tracheostomy and a PEG versus palliative extubation. If you have somebody who gets stuck in a chronic disorder of consciousness, like a vegetative state or the minimally conscious state, the decision to withdraw nutrition and hydration will take place more than a year or 2 years later, if at all, and it can be excruciating. So when you start managing these patients, remember that initial prognosis is uncertain, and especially in adults with intracerebral hemorrhage, self-fulfilling prophecies are well known. You prophesy a bad prognosis, and that is what actually happens. Neurosurgical salvage, especially in situations where there is rapid rise in intracranial pressure, decompressive craniectomy is the standard. But individuals who require decompressive craniectomy are also likely to survive with very, very significant disability, especially when you have a young adult who's then going to live on for 30, 40 years. That's a major decision. So because these decisions are not easy to take so fast, my general rule is a time-limited trial of full intensive care therapy. Because if foregoing life support has to happen, that decision can take place after 3 days and maybe even a little longer. This applies to adults. Obviously, this does not apply to younger children, but this would probably also apply to adolescents. Any individual who lands up, who has a GCS of 8 or less beyond 6 hours, which means that quickly reversible issues have been tackled, like hypoglycemia and so on, the chances of them having bad outcomes are somewhere in the range of 80% to 90%. Older adults, obviously more, maybe younger, a little less, but still, these are a significant number who will end up in one of these states. Mild or no disability with prolonged coma is a minority. And probably the best predictors are obviously etiology, the depth of coma, the duration of coma, but also signs. And probably the most important signs are the appearance of brainstem abnormalities, either loss of brainstem reflexes or the appearance of abnormal flexor or extensor posturing. And this is why this part of the prognosis starts to become clear by day 3 and is usually definitive by day 10 to 20. When you are prognosticating, and this is especially true of adults, remember that patients will improve, though with significant abnormalities. Neuroimaging is not definitive. And it's secondary involvement of the upper brainstem, the midbrain, that marks a tipping point with much lower probability for an independent outcome. Because the major concern is anticipated neurologic deficit. This is what you need to pay attention to. So conversations about limiting or withdrawing should occur roughly about 2 weeks after 2 weeks have passed. This is when you need to decide about a tracheostomy and a gastrostomy. And this is a fork in the road. So either you go on to these or de-escalate to palliative care, and you need to counsel patients and families appropriately. There is one more wrinkle that I kind of seem to identify, and that is that withholding and withdrawal are actually medically, ethically, and legally equivalent. But to the layperson, withholding is emotionally easier. So when we come to this point, typically I frame it by explaining to the family that extubation, which means removal of the endotracheal tube, is a medical decision. It's a medical necessity. We have to do it. But putting in the tracheostomy is their decision. So if you actually term this withdrawal as withholding tracheostomy, they find it easier in the clinic. And if you have to do a palliative or compassionate extubation, you have to make sure that this is performed in the ICU, there is symptomatic management, and if the patient survives, then you move them out of the ICU. Now, I have been involved in this issue since 2011, actually as in the legal part of it. It was only later that I got interested in palliative and neuropalliative care. But our group has been participating in the legal journey. And if you realize, the first major judgment came out in 2018. Dr. Sushma subsequently put out the AIMS guidelines on end-of-life care. She and I and others were part of the DNAR document. Similar documents came out from Kasturba Hospital, and my group has put out the advanced care planning document. But for your purposes, it is the AIMS end-of-life care document which is the most useful, because it has forms that you can use. But for us, there were still limitations, because the pathway that the judges gave in the original judgment was just too difficult. It was only in January of this year that it all got simplified. And I would strongly urge all of you, I mean, if you are involved in intensive care, to go through this document that came out in the ISCCM and the Indian Journal of Palliative Care way back, explaining how to take these decisions, at least as far as the medical components of these are concerned. So what you need to do is confirm consensus on futility. We need to have at least 3 consultants signing out. We call this the first end-of-life care committee. Remember that this can never be a unilateral decision. It has to have at least 3 doctors willing to sign on. You get consensus from the patient side and complete documentation. And the court has suggested that insisted that this must be reviewed by a standing body within the hospital. And again, we are in the process of setting up rules for all of this. So you need to be aware that all of this is now possible. Remember that neuropalliative care has three major issues. One is communication. In oncology, you give a diagnosis of cancer and your communication is largely done. That doesn't happen with us. Prognosis can be inconsistent, and the attitudes, skills, and information available change from patient to family to clinician and all permutations in between. Remember that neurological diseases impair personhood, and the most important is eventual loss of autonomy and control. Uncertainty is an absolute given, not just about prognosis and timelines, but often even about diagnosis in the beginning. And very often there is little certainty about information and support even from palliative care. So our patients live with all of this. I'm skipping over this slide just to point out that I run a course for neuropalliative care. This is, of course, focused on adults, though, I mean, it runs with a module a month in which we take cases. And 4 of these cases are younger adolescents. This course is meant to bring everyone on the same page for neuropalliative care, all professional streams, not just neurologists or palliative care physicians. Anybody, physician, pediatrician, anybody who looks after patients in this category is welcome. I am hoping to see a similar course being set up for pediatric neuropalliative care. The structure is that we work through modules. Each module has pre-recorded webinars and reading materials in 3 streams. The core stream is neuropalliative care. Then there is a stream of palliative care for neurologists and basics of neurology for non-neurologists. This is important because non-neurologists have a significant amount of neurophobia. They find it difficult to take on neurology cases. We have a flipped classroom. As of now, for the adult course, the annual fees, we'll be starting the next course on the 1st of July are about 40,000. I'm going to stop at this point. And if anybody needs the materials, you're welcome to email me, or even if you need any kind of, say, information about the legal issues and so on, please do go ahead and email me or WhatsApp. Thank you. Shefali, I'll jump off now so that I can come back on my mobile.
Sure, sure. Thank you. Thank you, Dr. Roop, for such an exhaustive deliberation. So now the house is open to our experts. And Dr. Sushma, would you like to say something before Dr. Viraj and Dr. Manjari are going to share cases? You want?
Shefali, I think it was quite clear that there is a need, and this need will come only when we realize that palliative care is something which we can provide right from the beginning. Once we will realize the need, then we will start integrating, and once we will start integrating, we will be able to get the essential elements what we consider that 4 essential principles of palliative care, that is care of patients, family, care provided based on assessment needs, and then patient, family, and carers have access to what are the local networks available which can help to the patient, and what is the evidence based which we can opt for our patient, which is culturally safe and effective. So I think there is a need, and it's high time that every hospital where pediatric patients and pediatric neurology is a dedicated active subspecialty, we should definitely integrate palliative care. It's going to be tough initially, but it is not very, very impossible task.
Thank you, ma'am. And I think, as was Roop suggesting about the course, Viraj, if it's okay, we can start one with the AOCN. Along with the SIG, which will be there, we can start some brief courses. Instead of having big ones, we can have some brief ones, and where we can develop our protocols for pediatric, neuropediatric, and obviously under the guidance of all the panelists today. I can, and you can share your cases. Then I would want Susie to talk about how what we are talking is much different from what it is there in the UK, and what are the lessons we need to learn from them, from your lessons. So Biraj, to you. Yeah.
Great. Yeah, thanks, Shefali. And Roop, that was a really amazing talk. I think you led everybody right through the start to the end of neuropalliative care in this short time. So really comprehensive talk. Thanks, Roop. So what we're going to do is, just run you through a couple of cases. I'll start first and then Manjri. Shefali, can I share my screen? Can you permit me to share my screen?
Yeah. Dr. Gautam, can you make Dr. Viraj the co-host?
So, I think while we're just waiting for that to happen, the background is, this is a case that I think kind of highlights some of the challenges that we see in our day-to-day practice, all of us, whether you're a pediatrician, whether you're a pediatric neurologist, adult neurologist, whether you're a palliative care physician or a neuropalliative care specialist. I think we all go through days where everything seems to be kind of dull, and we kind of take the day for granted. We take a patient for granted, and then something comes along your way and it's not as kind of mundane as we think.
Dr. Viraj, you can share now.
So what I've done is I've going to show you this case, and I call this a mundane Monday morning. So this is a story that I really think kind of will reflect what Roop has been talking about. And it'll highlight some of the skills that we probably should all incorporate into our practice, just as what Roop was referring to earlier. So the preface to the story is that my resident or fellow at the hospital tells me that there's a run-of-the-mill, sir, this is a regular cerebral palsy patient that's coming in next. And that's how the story begins, kind of a so-called, as they say, the known case of cerebral palsy coming in, which is pretty much bread and butter for every pediatric neurologist, and nothing very different in this patient either, at least on the face of it. So Jaya is a 12-month-old infant that's brought to my clinic by her parents. She has severe cerebral palsy. She has severe cognitive language delay. There's minimal interaction with her surroundings. She doesn't seem to recognize her parents. There's obviously visual impairment from the extensive damage to her brain. And of course, she had neonatal seizures at the start. And like most of these children who come our way, there was obviously a very stormy late pregnancy, early neonatal period. During the last visit to the obstetrician, mother reports that the USG showed my baby almost died. And then an emergency C-sec was done. Of course, there was a severe birth asphyxia as expected, neonatal seizures, and the typical story of resuscitation, ventilation, and then finally just being discharged home. So the story really begins with I make a quick assessment, and then I turn to the parents and I say, what brings you here today? Because obviously this is a family who's got all of this told to them several times by several doctors before, and this is not new to them. The diagnosis of cerebral palsy and hypoxic encephalopathy wasn't new. So I just asked them a simple question, what brings you here today? And it starts out with, my baby's very irritable. She has abnormal posturing of her limbs. She's constipated. She has feeding and swallowing difficulties. She drools a lot. So right off the bat, lots of symptomatic treatment and care that can be provided. Obviously, palliative care is a lot about also providing symptomatic care. And there's obviously enough of, kind of things that could be done for physical symptomatology of this baby. And then using some of the communication skills that Roop highlighted earlier, it's simple tools, these are simple statements, simple, but yet very powerful, very effective tools that we all have in our repertoire. Simple statements, tell me more, respond to the emotions using NERST, what Roop talked about earlier, using reflections, and of course, a very, very important rule the ask, tell, ask kind of way in eliciting more information and conveying information to the family. So using this, the plot thickened. The parents now started talking more, and mom was really taking over this conversation. And she says they recently transferred from the Mumbai to Delhi. She said, and I could start sensing the emotion in her voice. Dad works in a bank. He's away all day. Mom is with the baby all day. So, just the way she said it, the tone in her voice, the emotion was kind of evident. The frustration and the emotion was already coming right through. There's no relatives in Mumbai. There's no support system in Mumbai. So she had so much of kind of baggage that she started kind of sharing already. And then the emotions really started flowing. A few more questions, a few more kind of nods from my side, and she started kind of just opened up completely. She says, I cannot put my baby down even for a short while. I cannot even bathe in peace. I know she will always be dependent on us. I'm all alone. Why do you think this has happened to me? Is this my karma? Can you help my baby? She must be in so much pain. Why did the obstetrician save my baby? She should have left her in my womb to die. She saved her too quickly. Can you give my baby some poison? I wish my baby dies. Does that make me a bad mother? If I kill my baby, will it be a sin? I know I'll be okay if someone just takes my baby away from me. So this was the kind of emotion that she shared. This was, it was one after the other, and there's just so much, and there's just that much of emotion. There's that much of kind of depth to this conversation, and I think this kind of conversation just showed so much about what she was going through and all the different kind of thoughts that were running through her head. And just like that, this Monday morning became suddenly very, very meaningful. And I think this is where I'd like to kind of say, if we can take a little bit of time, perhaps a few minutes, and get our other members of the expert panel to just kind of reflect on what's happened. And maybe we can kind of jump into that, and, whether Roop or Manjari or Susie or Dr. Bhatnagar, anybody wants to have some comments on this and thoughts on this, and let's talk about what we kind of see or hear or learn from this case. So
I think very well presented case, Viraj, and it is thought provoking as well. I think this is so important that in a hospital, I don't think that we are giving enough time to the such mothers. And, child is there and they are having a lot of symptoms. We can improve the symptoms, and that is definitely that is definitely most of the hospital must be doing. Otherwise, if they are not doing, then we should have a protocol wise that at least they should be symptom free. But the the bigger thing is happening with the mother, and I think this needs good communication skills from the physician side. We need to have a good support groups so that they can help them, and maybe some kind of a cognitive behavioral therapy with the means, like they are meeting with other mothers and how they are coping with. I think it is a very, very eye opener and very thought provoking case, and case reflection, and I think we are not doing enough for these kids as well as mothers as the caregivers.
Dr. Susie, you've raised your hand.
I think my first comment would be to say what absolute bravery from a parent to speak so openly with somebody who is absolutely in a position to help, but families so often feel judged if they are that open and that honest about their experience. And I think Roop alluded to it earlier on in his talk about acknowledging those emotions and allowing that that parent to feel okay that actually those are the emotions that they're going through, because that gives them, I think, the security to then work hopefully with you and alongside you to try and make things better. But that open communication is so important. And I have very similar, I can absolutely think patients come to mind, don't they? Whenever we share patient stories, you can think back in your own head about patients that you've seen where you've had not the same, but a similar experience where a normal day has suddenly taken on very significant meaning.
Manjari, you raised your hand.
Viraj, thank you for that fantastic case. And clearly, I think it speaks to the communication skills yourself and your team, where you made the family feel safe enough to share what could be perceived as some rather distressing information. So I think here's the thing. What stands out to me is two things. One is that this is a baby that is highly symptomatic, and we're already talking about neuroirritability. Is it seizures? Is it feeding intolerance? Is it reflux? All of those things, and they could be managed with some medication. Of course, these symptoms are often quite hard to manage at the first instance, and it's a matter of patience and trial and error for the medical team that's treating them. The other thing that stands out more than anything else is the caregiver stress and potential burnout. So that's when you really want to have your interdisciplinary team around the family, where you have social workers and even volunteers who could think about ways where this family could be, or the mom could be, practically supported in caregiving. Could she take a small break? It might be just a matter of going out to run an errand for grocery or getting her hair cut. If it's just half an hour, maybe once a week, is that a support network that's available? Is there any additional support that is available? And often, even though that kind of labor is cheap in India, it's still a burden to families. So a lot of these practical planning issues. And I'm sure your team did all of those things. And I don't know, I mean, we would like to hear a little bit more about what happened further, if you have those details as well.
Yeah, I completely agree. I think, if we were to look at how we could manage her, it would be really such an intensive multidisciplinary approach that we need for mom. I mean, the patient aside, of course, as you correctly said, there's a lot of physical symptoms that we can treat, but I think that's perhaps in some ways the easier part of this kind of scenario. And I think one of the reasons why I show this was to show the far more challenging aspect of how are we going to help mom, and how are we going to help this family, obviously going forward. And throughout this entire 1 hour that I was with the family, there was so much of emotion from mom, and dad was kind of quiet. He didn't speak much, but there were just tears streaming down his face. So while the story is all about mom, there's also a lot that was unsaid by dad, but I think his kind of facial expressions, his body language also conveyed a lot, And right off the bat, when we hear that he's away so much and she's all alone, the tears started falling down from his face. And I think there's a lot of guilt that's also packaged in. Guilt on his part for not being there for the family now, or not being able to be there in his way, or in his head. Although obviously he has to work, because taking care of this child, managing home and all of these things requires a lot of funds, and it's not easy to gain resources. So many different layers to this, from mom's mental health to giving the right treatment, to the resources, to respite care, like you talked about. Can we get some time off for mom, an hour a week or 2 hours a week, and what a difference that can make some time, to psychological counseling, to perhaps even some amount of psychiatric treatment or drug treatment for depression and anxiety and everything else that she's going. So many different layers that we need to think about for the parents, so very, very challenging, I think. Yes.
Viraj, may I add something? I mean, here you were able to relate, sometimes parents, they must be educated and, they could relate. But there was one case, I mean, I remember that there was an SMA patient on ventilator for long, and they were from a low socioeconomic status, and that ventilation went on for months and months. And they were counseled many times. The tracheostomy was done, everything. Obviously, it had to be done for prolonged ventilation. And we had counseled for home-based ventilation, and we had arranged for the ventilator, tried to explain to them. But, the father was working in a beauty parlor. So obviously, and he was, must be one attendant kind of person. So he was not financially well off. One sudden morning, after a couple of months, in the morning, the father used to, stay the night. At around 6:30 a.m., the residents were called. It was in the high dependency unit that the child had an arrest. And we found that there was a disconnection of the ventilator from the tracheostomy site. And obviously that was done by the family. So I'm just saying that, I still remember that case. And I don't know, how they took the step, and we also trying to counsel. So, it is very complex, all this. We have to make it much more simpler. And then obviously nobody raised an issue because, the nurses had not done the bed change or something. There was nothing, there was no handling. So obviously it was unsaid that we understood that it was disconnected by the family, but, like the way it happened. So, they go on through so much of turmoil, and also I think there's very much issues to address. In that also they knew nothing going to happen like they knew in this case.
So Shefali, in this scenario, I think if the physician can help them, because if we start explaining them early, I think we can explain them this is that withdrawal or the decreasing support. This is not a bad thing which we are doing. I think this has done, and the father will remain always guilty that I did disconnected. But if physician could have helped them by supporting what since long, I think it is not that at the end, I think for months together, if child is on ventilator and then he's disconnecting in frustration, I think this is what our deficiency in medical care, that we should have done it before, that we should have started explaining, and withdrawing is not a wrong thing in such cases. I think this is deficiencies in our care.
Ma'am, he was counseled. But the only thing was mother was hell-bent. Nothing is going to happen. They were not that educated. And I think we had involved your team also, and they were counseled. But, the point is, it was not that the counseling was not done. It was done, but the mother was hell-bent because the gender was, it was a boy, and the mother did not want to step down, the support that was.
So I think Manjari has
withdrawal case.
Yeah.
Yeah, so before I jump into the case, I noticed that there are a couple of rather important questions in the chat. Maybe Roop or Viraj could
I'll take them.
Yeah.
I'll take them.
I'm going to try to share my screen in the meantime. I can't share screen. Can I be made co-host?
Dr. Gautam?
Yes, I have made, ma'am.
Thank you. So let me begin by saying, first of all, that this is a case in my current practice in Kuwait, and that the medico legal obligation of healthcare providers is to offer full resuscitation to all patients irrespective of the prognosis. The only way that could be prevented, if appropriate, is if the family seeks out a specific order from the Ministry of Religious Affairs, which very rarely, if ever, happens. So there's an obligation to provide full resuscitation. So Viraj, none of my days are mundane. Anyway, so running through this one, also to point out that, you know, this part of the world is really a petri dish of very rare genetic diseases, and that's because it's a small population with a lot of consanguineous marriages happening. Anyhow, so we're currently caring for this 2-year-old baby who's Iraqi. So they are expats with limited access to healthcare. Healthcare within the hospital setting is free, but as soon as they go home, the cost would entirely have to be borne by the family. And those costs are prohibitive in this country. So 2-year-old Iraqi boy who was admitted to the intensive care unit about 4 months ago with pneumonia and respiratory failure. His twin was, the identical twin was admitted at the same time, but that baby died of the pneumonia and he didn't make it. Our patient required endotracheal intubation and invasive ventilation, and he currently remains, ventilator dependent. He's nasogastric tube fed, obviously has very severe microcephaly, practically no developmental milestones to speak of. Hypotonic, has seizures that are controlled on multiple anticonvulsants with rather infrequent breakthrough seizures. He's now under the complex care unit, and so the complex care unit is the taxonomy is also a little bit of a taboo where I work. So we are complex care and palliative care, but we are also the PICU too. So I'm not really sure what it is that I do anymore. And there's a lot of serendipity in the way my day-to-day work goes on. And, you know, maybe I'll talk a little bit more. Anyhow, so currently this baby is on endotracheal tube with ventilation. Not a candidate for tracheostomy because would not be able to withstand any amount of anesthesia. He's very frail. He's on SIMV pressure support with minimum FiO2 with reasonable pressures and reasonable rate settings. He is on multiple anticonvulsants, also on some gabapentin and morphine for pain. On scopolamine and secretions is quite a big problem. So, you know, the secretions often make the tape that is anchoring the endotracheal tube moist, and you know the tube has extubated about 4 times over. Every time this baby has been reintubated. He remains stable and does not show any pain behaviors despite his very, very limited cognitive abilities. The parents visit on a daily basis. In our hospitals, it's not mandatory for patients to stay with the babies, especially like in high dependency units. I really want all of you to, you know, have some discussion around this, because this is not typically a case that might perhaps happen in India, or perhaps it might. And I think it's actually, these were some of, I mean, of course, you know, sulfite oxidase, very rare syndrome, really no treatment, no disease modifying treatments at all, and death within few months. But this child has lived to over 24 months. So these were some of the things I thought we could talk about. What are the burdens of the current ongoing treatment? What are the benefits, if at all, given that this is a relentless disease without any hope of any disease modification? What would we consider in terms of prognosis for survival, even in the short term? What are the considerations for quality of life, the parents' wishes? And as I said, I mean, this is against a background of the medical obligation to prolong life no matter what. So over to all of the experts for your comments.
Wow.
I think this is, sure, good.
No, go ahead, Rup. You go ahead.
I think this is really, really tough, and I can see where you are right now, because we were there till a short while ago, and it's only now that we have some clarity on how we can proceed in these issues. I suppose you're, in that sense, doing the best to manage comfort, especially since pain is controlled. isn't it possible to communicate this to the ministry? And have you discussed the possibility of withdrawal, or what happens if he fails intubation at a certain stage?
So here's what happens. The ministry really will not get involved. Again, this is the harsh truth of life in the Middle East, because this is an expat family, and they're Iraqi, so it's going to be tricky. What we have done in the past, and this is definitely not what is best practice, is that we have tried to sort of align the patient's best interests, where the families are understanding that it's a life-limited condition and they're not really willing for further escalation, or they're begging us for extubation compassionately. But we can't do it because, I could end up in jail if I do that. So we have sort of de-escalated treatment, whether it's in terms of reducing the ventilatory support, or not offering a tracheostomy, or not doing very aggressive treatment if these children develop a ventilator-associated pneumonia, but at the same time making sure that they are as comfortable as possible. So that's really the part that we have been doing. To me, I mean, this is something that does provoke moral distress. Also making it tricky, and I'm sure the situation is better in India now than it was before, is that I'm literally the only pediatric palliative care physician in the hospital, or rather in the whole ministry, outside the hospice where I worked previously. So there's not many people who get the language or the thought process. So, that does make it more tricky. Again, back to you guys.
Yeah, I was just going to say, along with Roop, I share kind of his sentiments. I think our whole ethos of palliative care and what we all strive to do becomes so complex when there's a kind of, as you put it down on the slide, professional obligation to prolong life. I think the legal aspect of that is something that one has to really navigate very carefully, because there's our, ethos of being palliative care specialists or subspecialists or people with special interest, or even just pediatric neurologists or adult neurologists who see these patients and families on a daily basis. And we want to do what's actually in the best interest of the patient and always best interest of family. But how do we balance that when the law, demands otherwise? And from what you've put up, it sounds like it's not just necessarily ventilated related laws or DNR related laws or withdrawal of life-sustaining means, but it's an obligation to prolong life notwithstanding. So that could actually even mean things like giving meropenem and high-grade antibiotics and whatnot for a pneumonia and the thing, even though we want to de-escalate that, because we know that life-sustaining measures are probably not going to help this family in any way. We probably still have then, in this situation, a legal obligation to do that, so it becomes really difficult. I think this is really, really challenging. I think this futility of treatment is going to be quite challenging under this circumstance.
So I live on a wing and a prayer, hoping that no one makes a complaint and I don't get arrested. Yeah, but that's not the message here.
Yeah.
Susie, you would like to? Dr. Sushma, you were saying something, please.
No, I'm just saying quickly that Manjari, this is quite challenging because you have learned something else and you are doing something else. So I think it is quite challenging, and we are not. You are in a foreign land, so, and where the laws and rules are very, very strict. So I can understand your agony and your dilemma, that how you must be feeling right now. So I hope that the ultimately rules will change sometime.
Dr. Susie?
I was really going to echo what the other person just said. I mean, I can absolutely understand your moral distress in that situation. And you've made me feel very blessed and very fortunate to work in the culture in which I work, where we do have the opportunity to consider and very openly talk about the best interest of the patient. I would say that perhaps some of the moral distress that I witness, particularly in the critical care setting, is the sort of opposite situation, which I'm sure some others will be familiar with, where actually families are advocating for us to prolong life, when, as a medical fraternity, we believe that the ongoing life-sustaining treatments, burdens of that, and perhaps the burdens of the disease outweigh those benefits. And we've had some very high-profile court cases in the UK, which I'm sure have been reported in some way, shape, or form, where you guys are. And so we see the moral distress of continuing life-sustaining treatment, because if we don't have consensus in this country, then we're asked to go through the legal process, and that is quite time consuming. But I come back to saying I'm very grateful that our legal process takes a different stance to that which you're experiencing, Manjeri.
Thank you.
See, any suggestions to us from your experience and what you have seen, the dilemma we face in India, and now Manjeri is facing a different kind of dilemma in Kuwait. So, I mean, how we can move forward for providing better neuropalliative care? Any thoughts on that which may help
No,
us?
in this case, Shefali, it is best that we should do in the best interest of the patient. Whatever we are explaining, we should document whom we are talking. If we are having any family meetings, so we should document that who all are present, whether they are giving their consent. It is not necessary that they're signing, but if they are accepting our understand what they have understood, we should write down. So documentation become as a very, very authoritative legal document for us, that we are communicating it regularly to the family members. For these are the family members whom we have communicated, and document it properly and do it in the best interest. It is not necessary to prolong suffering like this always.
And I think we need to have a witness to sign, because if you're writing all this, only one person should not be signing. We should have a witness who's signing, even if the parents are refusing to sign, right? So that at least two people signing would be better off. Is it?
I think when a resident doctor is writing notes and documenting, even if the consultant will countersign, this will become a very authoritative document, which can be. I don't think that if we are communicating well, anybody will go to the court or there will be any legal problem in India. It all happens when communication is lacking. There are enough evidence all over the world in various aspects in cancer as well as in non-malignant diseases, that the lawsuits happens only when there is a lack of communication or gaps in communication. So it is very important that how we are communicating. I think we have to give lots and lots of importance to communication. We have to teach communication, because it is, and when we will start communicating, every patient is going to be different, but we have to teach them how empathetically we can talk to the parents, and documentation is very important. So communication and documentation is very important in these cases. We can do everything with these two.
Absolutely. I think you're absolutely right. I was asking Susie overall, not only for the case, overall for neuropalliative care. Any thoughts she has to, after listening to our side, for us?
Well, that's a very big question. I think what has been sort of discussed today are very much the same struggles that we have, which is how do we integrate palliative care in such a way that it is acceptable both to the patient if they have capacity, to the family, but also to sometimes other professionals that we work with who may have a very different set of beliefs around palliative care and the provision of palliative care. A lot of my work in the last few years has been about increasing our sort of visibility around the hospital to try and ensure that we work really proactively with colleagues in oncology, in critical care, in cardiology, to provide that support from the point of diagnosis or soon after, if that's appropriate, and then to sort of walk alongside, you know, families, but also the MDT that's working with patients. You know, so much of what Roop said, I could find myself repeating, so I won't. But you know, things like you know, making sure that we have a really good attention to detail on symptom management, and we're very fortunate that we have got access to lots of medications, and we're starting to look at and work with centres across the country. You know, even in this big children's tertiary hospital, there's only 2 whole-time equivalent palliative care consultants, so we're trying to work more collaboratively
One
with other
second, Susie,
colleagues.
can Manjari, can you stop sharing? Then Susie can be on the full screen. Yes, sorry. Sorry, Susie.
That's okay. No, so just trying to do things, on a bigger footprint. I don't know if you guys have seen things like, we have a website called the Association of Paediatric Palliative Medicine in the UK, and I would recommend that to yourselves. That we also have Instagram and sort of Twitter accounts, and we're trying to sort of come together so that we share learning and share experience, because we all have relatively small numbers of patients, and so there is that opportunity for greater learning if you go national. I probably leave it there in terms of what I think I can share, unless anyone has any specific questions that they want to ask me.
Roop, can you go through the questions, please?
I can't see anything. Are there any questions?
Yeah, Viraj, you want to go through the question?
I think I see that there's one question that's been asked by a parent of a young adult DMD who has sleep and psychiatry issues and refusal. Okay, so I think what the parent seems to ask is, it is extremely challenging to find a palliative and or respite care for DMD patients, and also to find doctors familiar with DMD issues. So what options and recourse do we as aging parents have? So I think if I were to answer that in 2 parts, as far as DMD management is concerned, I think we're a large group of pediatric neurologists in this country, and I think many of us in our fraternity do see and treat patients with DMD. So I think you know, if the person concerned would like to reach out to anybody who's a pediatric neurologist in this country, I'm sure they can help you with that. I'm not the second part of the question about respite care for DMD patients and families. Very few centers actually have official, well-organized respite care centers, and I think that's something that I think is much needed. I think having some kind of place, some kind of protocol in place, and some kind of infrastructure in place for families who go through life feeling isolated without any help and support, much like the mother that I was talking about, it would really be very useful if we can get a lot of infrastructure in place to deal with issues like this. I think providing support to families who feel isolated is such an important aspect. Support groups, official peer support groups is so important, especially for families who don't have the social support within their own community. So I think that's a very valid point.
I think one of the things that we can do is actually, as neurologists, is to connect patients and families like this to formal palliative care that is already available. One of the things that happens is palliative care, people in palliative care are very uncomfortable about managing neurological issues. If we can just connect, we actually can take things forward, especially when we see distress that maybe as neurologists we find difficult to handle. Especially, I think DMDs with respiratory issues. Yeah, I think starting helping with morphine, deciding about NIV, those are things we should be able to help with.
Any final last messages from the panelists? Then we wind up. We've crossed our
Yeah.
final messages. Viraj?
I think we've pretty much covered a lot today. So, you know, thanks for having me as part of this discussion. Thanks, really.
Thanks, Manjari.
And this has been an excellent and very detailed discussion. And I think the way forward is collaboration, you know, neurologists, pediatricians, general practitioners and palliative care, because we have to pool the resources that we have. And that's the way forward, I think.
Dr. Roop?
Yeah, I agree. I think collaboration is the most important. We all need to reach out to each other, and I think we need to make tools available for training as widely as possible.
Dr. Roop, we are making special interest groups in Association of Child Neurology. So we'll be making one palliative care one, and probably be starting some training courses also in that. And we'll need the collaboration with all the panelists here today. And final word from Susie, our guest.
No, just to say thank you so much for inviting me. It has been really, really interesting, and I would be more than happy, and I've got colleagues I know who would also be more than happy to support training, as long as our time zones can make it happen.
Thank you so much. Thank you so much. I think Mahesh, you want to make your own comments before you put the closes? Your comments, Mahesh. Yeah.
Yes, ma'am. I think we as pediatricians, most are not very oriented towards this neuropathic care, ma'am. And I think we all should know about this and practice in our, we are doing it in a very informal way. Especially, I think for most patients, especially in Belgaum, we don't do feeding gastrostomy also. Like, kids are on NG-tube for months together. Simple thing like feeding gastrostomy, many parents are not open to. And even when I spoke to my pediatric surgeon, even they're not very keen in doing feeding gastrostomy. They feel that they're wasting money and time. So this type of change in attitude we need to bring into our own colleagues' mind also, plus among the patients also. And I think way forward would be to have patient groups now. Actually, once we have a good number of patient groups, we can they can demand for it, and we can do a lot of discussion.
Yeah, we can obviously
You're muted.
I think we can wind up. Then you can put the closing remarks. Yeah, thank everybody for this. Yeah.
I'd like to thank our speaker, Dr. Roop, for a wonderful coverage of this topic of neuropalliative care. I would like to thank all the 4 experts who gave their valuable inputs and made this meeting a success. I'd like to thank all the members who attended in big numbers today, and those who I'm very sure they will benefit from this webinar. We'll be continuing to have this what to expect sessions, and the next meeting will be announced shortly on both WhatsApp and on email. Thank you, and good night.
Thank you. Good night. Thank you. Bye. Good night.